presented, I will include it into my case record form in the eligibility form as well. There we go.
Can you present more about the inclusion exclusion criteria and the study factor that you would like to collect because it's very important for the data record form.
Okay, I will present it another time. So the participants inclusion criteria are the patient who is more than 55 years old and diagnosed as T2DM by this criteria, including ICD-10 and the laboratory level and the treatment they got, and as well as the patient with diagnosed as osteoporosis, which is identified by BMD T-score at femoral neck minus 2.5, or there has history of osteoporotic fracture identified by ICD-10, and the fourth one is the follow-up period at least 1 year. For the exclusion criteria, I will exclude the secondary osteoporosis, including this diagnosis and the diagnosis with bone quality themselves, which is the condition like osteomalacia and Paget disease. And I will exclude the patient who got more than one treatment and who continue the treatment less than 6 months. For study factor, I will for the treatment group, I will focus only on denosumab 60 mg subcutaneous injection every 6 months, and other group or non-denosumab group included other osteoporotic treatment like arendronate, risidonate, solidonate, and teriparatide on the dose that is mentioned. For the core variables, I will divide it into 3 domains. The first one is demographic data, age, sex, BMI at baseline, ethnicity, occupation, comorbidity, smoking status at baseline. I mean, like current smoking at baseline. The care scheme for osteoporosis related factors. I will collect the duration. I will collect the duration of osteoporosis from the diagnosis to the index date, which is the date that we start the indexment. The history of fracture, baseline BMD, systemic corticosteroid, proton pump inhibitor, calcium supplement, vitamin D supplement, and baseline calcium and vitamin D level. For T2DM related factor, I will collect the duration from the diagnosis of T2DM, baseline fasting plasma glucose, hemoglobin A1C, and creatinine, and the insulin using history of the patient. And for the outcome, I will focus on the primary outcome, which is the diagnosis of osteoporosis, osteoporotic fracture from ICD-10 and PAP. And for the secondary outcome, I will follow the change of BMD, fasting plasma glucose, and hemoglobin A1C. For the data collection, the patient who is diagnosed as type 2DM and osteoporosis age at least 45 years old will be identified by merging the data from established T2DM Raama data warehouse and osteoporosis data. For the blue boxes here, we already have it in our data warehouse. But for the orange one, for osteoporosis, we have to retrieve the data. For these criteria, which is to get a patient with osteoporosis, I will include the patient who got diagnosed by ICD-10 directly osteoporosis. And for BMD level, for BMD at femoral neck less than -2.5. And for the one that BMD is not reached the level for osteoporosis, but they already got osteoporotic fracture, I will merge it and make it this is the diagnostic criteria for established osteoporosis, and as well as the patient who got osteoporotic treatment, but I have to exclude the patient that got some osteoporotic treatment but didn't got the osteoporosis, like someone who got alendronate according to their calcium abnormal level. And then I merge these two groups to get my patient of interest. For data collection, I will collect demographic data, physical examination, laboratory data, medication, diagnosis from ICD-10, and as well as the imaging for diagnosis of fracture or fracture from PACS. And this is the case record form for the eligibility form for inclusion and exclusion criteria. I will collect the patient ID, date at enrollment. For inclusion criteria, first one that age more than 45 years old, I will collect their date of birth and calculate their age at enrollment. And I will collect the date they diagnosed T2DM osteoporosis and the date of starting the osteoporotic treatment. And for the this is for the inclusion criteria that they got more than 1 year. And for exclusion criteria, for those diseases for secondary osteoporosis, and this is for the month calculated for exclude the patient who got osteoporotic treatment less than 6 months. And for the case record for the enrollment form, which is the one that already included into the study, I will collect the data as I show you in the covariates earlier. I will collect gain age, gender, ethnicity, occupation, health scheme, comorbidity, medication, and physical examination. And continue for the enrollment form for osteoporotic related factor that I already provide, and T2DM related factors. And the third form is for the follow-up form. I will collect date at follow-up, the number of visits for the index treatment, and collect that whether they change the treatment or not. For the physical examination for some adverse events, and laboratory investigation for fasting plasma glucose, hemoglobin A1C, and creatinine. And for the imaging like BMD T-score and the fracture during the follow-up time and the location of fracture. And this is the end of my presentation. Thank you very much.
Yeah, thank you very much. Do you have any question or comment from student? Uh, may I ask about the follow-up form? So I must say that if there is changing of the treatment of osteoporosis treatment, will be record, and when we use the follow-up form at that visit to record, we know that the patient got the drug prescribed at that day. So when we do the record form, whether it changed or not, we need to compare to the past visit, right? Or to use this form.
For the index treatment, this just means that what treatment that they already got.
At the day of follow-up, right?
Yes.
The day follow-up, and so if they got alendronate, for example,
for the first visit, and this is the second visit, and they change into let's say denosumab, so we ignore here for change.
Or if there is no change,
if there is no change, we ignore, but if they change the treatment into denosumab, we think yes. This index treatment should be the same for every follow-up. I mean, and changing osteoporosis treatment should be no for the one that still in the study, in the course.
Any question from student?
I think that every student should have at least one question. Please do not just keep quiet. Ask question according to Tanva's presentation.
May I ask another, Tanva, if there is no physical examination record at that day, there is no record. So what do you think? What can
I should add the missing value box for this. Because the reason why I put this, because if there's any side effect or maybe the reason why they change the treatment, I'd like to know as well.
You may need to think of deciding this form. Think of if you're going to extract the data manually from medical records, or you are going to retrieve the data from hospital system. Now with the big data like this, that you need to retrieve the data from medical from hospital system rather than going to review one by one medical record. That's impossible. Okay, incorporate that concept and the possibility and feasibility of data or availability of data, and then think of how the data should be stored in hospital system. The way you design for physical examination, GA, I thought that is general appearance, right? So that general appearance that shouldn't be recorded unless that you assess the medical record and you read as a whole progress note on that visit, and you make decision. You make decision later. But think of if it stored in the hospital system in terms of vital sign, in terms of body weight, in terms of organ saturation, something like this that never included and documented in hospital system, computerized in the hospital system. Okay, and the rest are the same that for neuro extremities, abdomen. So this is very old style, very old style. You have to think of what should be stored in computerized system in the hospital. Okay, it's not the way to extract information from the medical record from EMR at all. But what now we document in our computerized that should be able to let you classify in terms of whether the heart rate is normal or not, systolic blood pressure, diastolic blood pressure, or in lower threshold or not, something like this. Or respiration, but not general physical exam like this, because we are not going to review medical record. So incorporate now what should be and how should be storage in the hospital system databases, and design the form properly, not manual data extraction, not prospective data collection either. Okay, please ask question, student.
Thank you for your presentation. Because I don't know about the drug treatment of osteoporosis. So in the index treatment, did the patient get more than one of the medicine? If yes, I think we have to add about the number of drugs.
But only one treatment at that time. But for the dose, I think it is quite fixed dose for the osteoporosis treatment. So I didn't provide the dose variation here in the form. And I'm not sure whether I answered your question.
And what about the vitamin D supplement?
For each product form, okay, maybe forget to add it in the form. Maybe I will add it as well for supplement like vitamin D because
Other students, do you have a question or comment?
May I ask a question?
Yes.
sure.
Can I see the eligibility form? Yes. So there are a lot of disease in the exclusion criteria. So if we cannot get every disease from the electronic medical record, so how would you handle that situation?
For identify the diagnosis, I will use the ICD-10 for these diseases and to exactly sure whether they got like hyper or hypothyroidism or not, maybe I have to include the thyroid function test value if they got into the criteria for each particular disease as well. Maybe I need this more detail for identifying each disease here. to make sure it's really yes or really no. Because if we look only in ICD-10 and they didn't record it in ICD-10, maybe we might miss some case. Like malignancy, there's a lot of malignancy, so like hematologic malignancy or the mass malignancy that I have to include many ICD-10, I think.
How you deal with this problem if there are many malignancy or cancer?
At first, I will include the ICD-10 for which is for malignant neoplasm, like many codes, and as well as a pathological result maybe need to be retrieved as well to make sure.
If the osteoporosis happen before the malignancy, you will include, right?
You mean the diagnosis of malignancy during the follow-up?
Yes, or because if you will, the patient or the participant in your study is not the newly diagnosed osteoporosis, right? Maybe some patients are the old cases. So if they have the malignancy after having osteoporosis, you will include or not?
I will exclude them.
Even if it happens after diagnosis of osteoporosis.
Because for the malignancy, we're not sure that if this patient got fracture later on, he is not sure that this fracture is come from osteoporosis from the first place or from the metastatic malignancy. So I think no matter which when they got diagnosed malignancy should be excluded.
For the changing osteoporosis treatment, you will exclude or not? Because it's not in your exclusion criteria for changing the osteoporosis treatment. It's not in your exclusion criteria, right?
Yes, also. Yeah, I collected here changing osteoporosis treatment.
Because in your exclusion criteria, you said that you will exclude patients who use more than one osteoporosis treatment.
Yes,
Not changing, but use more than one.
use more than one.
In your
okay.
exclusion criteria.
In my, yeah, maybe according to the wording, maybe I have to change to use more than one. Because changing osteoporotic treatment is like you use another class of treatment.
Yes, you will exclude them.
Yes.
Why?
Because within 1 year of follow-up time for BMD, the treatment, I think it should be like the same because to clarify the effect of the treatment.
But if you include the patient and they switch the treatment after inclusion, you will exclude or not? Because in your follow-up form, you say that the patient can switch the treatment, right? in the follow-up form.
No, I had it to like during the follow-up, if they got another treatment, I could also exclude as well. So that's why I add it into the follow-up form as well. It is like when I like first yes, I think it's a matter of this is like the manually record form, and I will retrieve the data from the computerized data. So I think this is my problem. I decided just like I record it like manually.
But you will exclude if they change the treatment. You will exclude.
I will exclude if they got like 2 treatment, like different treatment during the follow-up time.
Different treatment.
No, he means combined treatment.
Yes.
Combined treatment that more than one treatment on the same time, right?
Not at the same time.
That's the which treatment.
Yes.
Initially, the patient might receive denosumab, and then later on, they might be switched to lenalidomide, and that each time they receive monotherapy, but they were switched treatment. Another type, they receive combined treatment, 2 medication on the same time. So which one that you would refer to? It might happen for both, even though it is less likely for combined treatment, but it might happen, very small. It might happen. So which one that you are going to exclude and why?
I think I will
You have to think that your study design is observational study, and you will use the real world data. This is not the randomized controlled trial that you have very strict criteria. Right.
for combination, for combined treatment like denosumab and other. I think it is possible that the patient got denosumab and then they switch to bisphosphonates later, which is normal prescription. Yes, and
Because when you, I think this is the observational study using real world data. So if it's very common to switch the treatment and you exclude many patients, you will exclude a lot of patients, right? If you exclude the patients who are switched the treatment later.
I think it's just I will exclude only the one that got complete. I'm not sure whether.
No, don't think too much. Don't think too much. Work on real world data. It could be happening that the patients receive monotherapy. Initially receive one treatment, and then later on they will change to another treatment. They will change to another monotherapy, or they will added another treatment on top of that monotherapy. So that combined therapy. It could be happen either way, and that you need to export the data. But what you need to know later, and you need to review more how to deal with the treatment patterns, because Not now the patients may not receive only one treatment for the whole. Now the rest now of follow-up, they might be switched to one or another, or they might now be add up now with another treatment. Okay, so think of how to deal with now the treatment, how to emulate now randomized control trial now using real data that you need to review more and more. Okay, but today it is about data collection, or what is it is about, or inclusion exclusion criteria as well.
record form.
Have we passed about inclusion exclusion already?
Right.
Okay, but today is about data collection, right? So we focus on data collection. Focus on data collection. And when you assess, even though that you're going to review data manually, extract data from EMR manually, or you're going to retrieve the data now from hospital databases. For each treatment on that follow-up, the patients receive or were prescribed what treatment, that's all. Whether they will change or not, that once you've got longitudinal data, and then you can assess straight away that the patients will change or switch treatment, or now are receiving combined treatment. Okay. But the thing here is that make sure that you design now the form properly, and make sure that you now have now thought of other medications that now can be lowering or induce the risk of osteoporosis as well. Thought carefully about other medications in which that you have yet to include in this form. Other medications. And here that we need the flow, because you are going to work on secondary data. You are not going to review medical record. So you need to show the flow to identify T2D and also versus that you mentioned for the previous slide. And on that flow, apply your inclusion exclusion criteria to show the flow. That is the main part of this presentation for working on secondary data. Okay. And the next presentation, we're going to talking about data analysis, right, Janti? For the next presentation?
Yes,ค่ะ.
And where about the exposure outcome measurements? Where are which presentation?
The previous session that we talk about the study factor and outcome measurement.
We had talked already for the previous presentation. That is okay. For the next presentation is about statistical analysis plan, right? You have to remind yourself and present to the participants here as well that how to deal with the treatment. Don't forget that. How to deal with the treatment regimens and treatment pattern. Okay. And then you have to read about how to emulate randomized control trial. Review that. And we have a few articles that are published from our team on how to emulate randomized control trial. That should be good lesson learned for you, right?
Do we need dummy table instead of CIF for data warehouse? Just asking.
Normally, when we're talking about dummy table, that dummy table for statistical plan, statistical analysis plan. Statistical analysis plan that you should present dummy table, how you would like to present result of this research. That is dummy tables. But Ajahn Puk might think of the table for the structure of data, right?
Like this structure, like domain.
Data structure.
Characteristic dome has age. six baseline characteristic and then another domain and variable.
Yes, that can be plugged into case record form. Case record form can be focuses on the structure of data for secondary data that you're going to retrieve from the hospital databases or the data record form for extract information manually or for prospective data collection. Can you go to the previous slide? Here that eligibility form that you apply inclusion/exclusion criteria. And the next slide, enrollment form that is baseline data. Okay, enrollment form that is baseline data. Make sure that you have the form beside the form, demographic data, and then comorbidity, and then the treatment at baseline. Okay, and physical exam, which is okay from here. But make sure that the medications at baseline, the core medications that may be induce or reduce the risk of osteoporosis in type 2 diabetes should be appear here and should be appear in the follow-up form as well. Okay, but the form is not going to include or extract information. The form is about the date prescription, the amount, the dose per day, and the amount of that prescription in order to let you calculate the duration of receiving the treatment. And here you are that you are working on type 2 diabetes, right? The patients are type 2 diabetes now who have osteoporosis, right? You need a medication for diabetes as well.
I emphasize this point previous that for the for type 2 DM treatment, I will divide it into insulin user and non-insulin user because as I review the literature, that denosumab might effective for the one that preserve beta cell in pancreas, which is the one that should not use insulin. I mean, for the one that use insulin, it means that maybe their beta cell is already dysfunction, and so I would just like divide it into two groups.
Yes, that your knowledge might be correctly that you can prove from what data show you, and just in case that you might lose or you might miss something, particularly for second-line medication, oral medication, and also injection as well. That a few medications have been reported that associated with osteoporosis for second line. Okay, so you have to review carefully. But here now the data now have more detail. Now we have all type of second line medications, and including insulin use and the type of insulins. And here you shortcut yourself. You limited yourself only use or not use insulin, given that the data are more detailed. Okay, so why not? Now, just in case that you have yet reviewed properly. So insulin actually, the effect of insulin just only hypoglycemia, and that make the patients now fall down and that fracture later. But second line medications, a few medications that have been reported recently during last 5 years that you need to review more about second line medication. That also affect osteoporosis and the outcome of osteoporosis. Particularly that you are now looking for fracture right? You are looking for fracture. So that if the patients receive a few second line medication, that induce more severe, more progression of osteoporosis and therefore fracture. And that co-intervention. So you need to review more, Hanwan. And it's specific for type 2 diabetes. And if you're going to expand for as a whole osteoporosis, not necessarily for diabetes, for hypertension, for chronic kidney diseases, so you may need to look at a specific medication for that diseases and drug interactions. Okay, and the patients might receive steroid. So steroid that induce disease progression for osteoporosis. But have you seen the steroid here? Have you?
Systemic.
Okay, good. But you may need more detail that the patients might have that different type of steroid use. And the NSAID.
I saw that the outcome is to be identified from not only IC10 codes, but also from PACS system, from the imaging system. So for the data for the PACS system, you haven't explained yet how to retrieve the data from that. You just said it in one sentence that you would I retrieve, but the data are either images or the reports that were written by a radiologist. Which one or both would you like, and how to retrieve or extract the data from there?
Yeah, about this point, I would like to discuss with the team first. Maybe I'm not sure that how the collection of PAC system in Ramatibadi work, but if their text data already, it would be very useful for retrieving the data. But this is in the form I just as Ajahn Amarit said that I do it I manually retrieve it. So maybe I have to think more about retrieving the data from PACS, and as well as the report form for the review. But I will combine together because some film, I'm not sure whether the radiologist report every film or not. But actually we should look at PACS as well.
You have to think of well, I understood that you are talking about how to verify the outcome.
Yes.
How to identify and verify the outcome.
Yes, firstly I will use ICD-10 for the fracture, but
can you use ICD-9 as well if the patients were fractured and then they got a treatment operation, so that you may think of.
That's only for hip, but for vertebral fracture, some patient might not get surgery. But it's like compression fracture, just only mild compression. But the treatment is to be conservative treatment, not surgery. So
yeah, only hip, but it's still better than nothing.
Yes.
So why not? Right? As many as possible, looking at the source to identify fracture. Not just the ICD-10, but ICD-9. ICD-9 might help you to confirm ICD-10. But if there is no ICD-10, but just the ICD-9, and the patients were also diagnosed as osteoporosis from ICD-10, so why not? That might be fracture according to osteoporosis. And then you need to verify according to the image. so that you may need to retrieve the reports according to the image and what type of image that you would like to get, and then you have to write down from this part the data collection.
I think there can be ICD-9 or at least service codes for rehabilitation as well, if they're not on surgery.
Yeah, and the next point that continue from Ajahn Amarin about flow chart in slide number 17. I think this slide is you need to add more information. Your study population is patient with DM with osteoporosis and receive the treatment, right? And this is for this flow chart. First point, you need to specify the time frame that the duration to diagnosis DM, and for osteoporosis, the duration to you will retrieve the patient that diagnosed osteoporosis during year 2019 to 2020. I think it should be in this flow chart, specify clearly about duration of diagnosis each disease. And my question is, in case that the patient has their DM and osteoporosis, if they diagnose, which one should diagnose first? That I think it's not possible that diagnosis DM and osteoporosis at the same time, right?
Yes.
How do you determine this is your subject, diagnose DM first and after that the osteoporosis, something like this, but I'm not sure. You need to specify clearly.
I think it's not it's no matter the diagnosis of DM or osteoporosis first, but once they already diagnosed both for the, no matter which one is the first, I will include.
Diagnosis DM in this time frame, 2019 to 2022, right?
Suppose that someone diagnosed as DM in March and then diagnosed osteoporosis in December. I will include them from December.
Yeah, it should be specified time frame clearly between diagnosis to disease. In your flow chart number 17. And another point is this is just only patient with DM and osteoporosis. If they did not receive the osteoporosis treatment, denosumab or other medication for osteoporosis, you will exclude, right? Because your subject is patient with type 2 DM and osteoporosis and receive the treatment. And in your flow chart, you have only the database for DM and the database for osteoporosis. And after that, you need to combine with the treatment. What treatment did they receive? If they did not receive denosumab and other osteoporosis treatment, because you are input.
I think Simon would mean milder cases of osteoporosis who were diagnosed with osteoporosis but did not receive specific treatment like bisphosphonates or denosumab.
Yes.
We need to exclude them, right?
I think for the one that didn't get any treatment, I will not exclude. Maybe I have to add it in one time.
for the treatment.
Yeah.
And the index date of your research is the date of received treatment. And your flow chart only have like a 2 items. I think it's better to add about after clarify inclusion criteria, and then another inclusion criteria is receive the treatment. Because this flow chart is show like how will you retrieve the data from database.
Then if possible, after the last box, now the patient now with T, 2D, and osteoporosis, regardless which one that diagnosis first. That's understandable for this box. And then you draw further, apply inclusion exclusion criteria, exclude whatever diseases, the hypothyroid diseases, whatever that are also associated with osteoporosis. Okay, and then come up with number, and then you split further according to your treatment of interest. All right, initial treatment. Okay, we are talking about initial treatment, and then follow up to the outcome. And that to the outcome fracture, you may need to include information to the flow that how to verify the outcome, and that you can see all the picture.
Don't forget to put other for variable such as the laboratory or the blood pressure, BMI in the follow-up form also. Any question or any comment? Second presenter.
Thank you for all of your suggestions and the comment.
So, good morning, teacher, and good morning, my friends. So, my topic is the effectiveness of combination of oxybutynin and trospium compared with increased dose after unresponsive to standard dose of single drug on urodynamic parameter in Thai traumatic suprasacral spinal cord injury patient. Recap a bit. In practice setting, the patient with suprasacral spinal cord injury with negative UDN parameter, they will receive the starting dose of the trospium or oxybutynin, which allow this dose. And if the patient have success in controlling the parameter of urodynamic, they will continue this dose. But what if the patient have still have the unfavorable urodynamic parameter? There is the variety of the practice, whether we combine the drug of oxybutynin and trospium or whether we increase the drug in single dose. So it come up with my objective that to assess the effectiveness of this two regimen when the patient have unresponsive to the normal dose of single drug. And my P population is the patient with traumatic suprasacral spinal cord injury patient and have unfavorable urodynamic parameter after the treatment of standard dose of single oxybutyrate or trospium. And intervention is combination therapy of the oxybutyrate and trospium at any dose. And comparator is the only single drug but increase from the normal dose. And our primary outcome is favorable urodynamic parameter when follow up. And the secondary outcome is urological complication and adverse event of the drug. The study design retrospective cohort, which recruit from the two center base and study period for 10 years at 2013 to 2023. And inclusion criteria, our cohort will be traumatic supraspinal cord patient with prescription of oxybutyrate or trospium. And inclusion criteria is the patient, adult patient age more than 18, diagnosis of suprasacral level spinal cord injury from trauma, and within 2 years of onset, with the unfavorable urodynamic parameter after standard dose, which defined as the oxybutyrate equal or less than 15 mg per day or trospium equal or less than 40 mg per day. And unfavorable urodynamic parameter defined as one of these parameters. And the patient have the prescription of intervention and comparator, which is the single drug or combination of the drug, and has at least one urodynamic evaluation after the treatment. And exclusion criteria is stated in here. The two intervention, the two therapy that I didn't include because it focusing our treatment only oxybutyrate and trospium. So I exclude the one who got the other kind of anti-muscarinic or invasive therapy. And the patient with history of the bladder injury or surgery and suprapubic cystotomy it is a limitation for urodynamic test, and the patient who have the previous urological complication before the treatment. So for study variables, the interested intervention will be combination of the drug, which can be categorized as the combination of high dose or combination of normal or low dose. And the comparator is the single drug, but increased dose, whether it is oxybutyrate or trospium, that the dose more than standard dose. And outcome is the favorable urodynamic parameter within 1 year. Secondary outcome will be urological complication and adverse event. I will give more detail in case record form. Co-variables at enrollment, I will collect the data of the baseline data, which consists of demographic data and spinal cord injury related data, and also the neurological bladder management data. And at follow-up form, I will focus on the co-variable of the neurogenic bladder management. So, and from data source, from demographic database and weight and height patient characteristic, will gather it from the electronic medical record and diagnostic database using ICD-10 for the spinal cord injury. Will focus on this group of ICD-10, which is S and T. And additional diagnosis that I can have recruit the spinal cord injury patient more is the diagnosis of the paraplegia or the condition which only happen in spinal cord injury patient like autonomic dyslexia or neurogenic bladder, and combine it with the medical database of prescription of oxybutynin or trospium. And for sure that I may need to manually check or retrieve the data from outpatient and inpatient medical record also. And the outcome data will be from the urologic report. And for the data retrieval, as I said earlier, I will recruit the data from 2013 to 2023 and exclude the exclusion can be stated as the ICD-9 also and ICD-10 of the diagnosis of urological complication earlier than the index date, and the medication of the antimuscarinic or botulinum toxin injection can be used for exclude the patient. And I will go further on the case record from for the inclusion criteria and exclusion criteria will be stated in the form yes to all for inclusion and no to all for exclusion. And at enrollment, the data demographic will be record. And spinal cord injury related data, which is the spinal cord injury onset, will be recorded as a date and calculate the duration later. And neurological level of injury will record. But this NLI and AAS will come from physical examination part. So maybe need to manually extract. And the other baseline data that I need to focus whether the patient have the treatment of the spasticity or not, and record it as the receiving of this treatment of spasticity or not, and function of the patient record it as the score of independency for the enrollment, and the neurogenic bladder management data, whether the patient got the first line of the drug, which is oxybutynin or trospium, and dose of it and duration, and type of bladder damage, and urodynamic parameter of the unfavorable study. What is the pressure, the capacity and compliance, and at enrollment we will also record whether the patient got intervention or comparator, record drug adjustment, whether the patient got combination of high dose or combination of normal or low dose, and what the date start, and adverse event if the patient have adverse event after single drug, that state in medical record as the covariate. And this is the enrollment form. The other one is the follow-up form. I will focusing on the dose of the treatment that patient got at that date, and also the treatment of doxazocin which treat the sphincter contraction. It can affect the urodynamic parameter, so I also collect it as the covariate, and the change of type of bladder drainage, and adverse event after the treatment, and also urodynamic parameter value of it, and urological complication from the image report or the physician note in a medical record. Yes, and that is all for data collection.
Thank you very much. Do you have any question, student, and comment?
Thank you for your presentation. My first question is, what is the enrollment date, more exactly enrollment period? So on that, from that day to that day, you will identify your disease population. So what is your enrollment date? But what I see is only, you mentioned only the study period.
What exactly enrollment?
Yes, enrollment period.
Enrollment period. What exactly enrollment period? The one with diagnosis of the spinal cord injury and got the prescription of the drug during study period. I will
So you
include
will include that all cases during your study period. For example, your study period end in December 2023, and if you identify cases, the first cases, one cases in December 2023, that might be problem. So that's why I'm asking.
oh,
The enrollment date or the index date,
Yes,
right?
and then
What is the enrollment date?
what is the enrollment date? So in this case, it should be not more than 1 year before end of the study period. I still recruit the patient at that time. For example, like if it end at 2023, the patient who got the index date before the end of 2022, I will include them. Yes.
But what is the starting date that you will collect the data from this patient? Is the date that they adjust the dose, right? After failing the first line treatment,
Yes, the index
is the first date that they adjust the dose, right?
Yes.
For the index date.
Yes. The index date, yes, is the date that the patient got the interested intervention, starting off the oxybutynin combination or increased dose after unfavorable neurodynamic parameter. I will use as the index date. Yes.
You go to the enrollment form. Enrollment form.
Enrollment form.
Yes, this the date of enrollment is the date that they start the treatment, right? That they adjust the treatment, right, for the date of enrollment.
The date of enrollment is the date.
It's the index date, right?
Is the index date. Index date will be clarified clearly at the part of starting receiving drug.
Start of receiving drug, you mean start at receiving single dose, single drug, or adjust the treatment.
Adjust the treatment.
So you take the data before the patient adjust the dose, right?
Yes,ค่ะ.
You will call, so the starting date will not start from the index date.
Or if I enroll the patient before the index date.
If you enroll the patient before index date, it's not met with your inclusion criteria, right? Because your inclusion criteria, the patient have to adjust the dose or have to combine the dose after failure.
Yes.
So if not met your inclusion criteria,
it should be the same date. Yes.
I think from อาจารย์ธนรัตน์นะคะ I think this is like a standard format for data collection form, but right now we change to get data retrieval, right? For the case record form, it's just like the map that you can imagine that what factor or what variable you will retrieve from the database. Because right now you haven't extract the data from medical record, right? We get the data from the database, and this is like a map. So I think it's better if you construct the flow chart as คุณหมอธันวาค่ะนะคะ that you will get the idea how you get the data. This is like the old style to collect the data. Okay? But when we talk about data management, that I divided into two parts. The first part is like the traditional approach that you extract the data from medical record, and another approach that I show you like how to retrieve the data. So the flow chart to retrieve the data that is necessary to get the idea. And what database that you will retrieve, for example, the hospital database, or even though like the database for specific database for some disease or for some instrument or laboratory, something like this, that you need to like review or think more about this point. So that's why Ajahn Thanara asked you about why you specify date enrollment in the form. That is not necessary because we haven't enrolled patient, but we need to like specify the immediate date of receive the treatment. And for the UMD data, right? Urodynamic data, can you go to the urodynamic data at the baseline enrollment form? Is the urodynamic data that is unfavorable, right?
Yes.
After prescribing the first dose of the yes,
Yes.
that you will define failure, right?
Yes.
This is the information of UMD that is failure.
Yes.
UMD. Okay.
So it will happen before the index date.
Yes, it
Yes.
should be happen before, but the date of UMD study after first line up is not corresponding with the data that you would like to get, right? Because this data is for unfavorable UDM. So it's not the date of UDM after first line treatment, right?
Oh, okay.
It should be the date of UMD that show the failure of treatment or unfavorable. I would like to ask you like how will you get the data? You will review the medical record because your subject is not too much, or you would like to retrieve the data from database, but I haven't get the idea. Like a two way or two approach that you can collect the data. It depends on your participant or the detail of or information that you would like to retrieve that is available in database or not. If it's not available, it is on medical record, so you need to review. That you know best, better than our team. In your specialty that I discussed with Ajahn Pulawa, that is not much subject and some information that can be not get from the
Just at first, the pool of the cohort, I think it need to be extract from the ICD. Yeah, extract it first from the ICD and the medication database, And after that, after extract the one with the ICD and also have the medication we interest combined together, and we got the data of the cohort. And then I think it may need manually review because the physical examination that need to manually extract the baseline data that I interest or we want to collect, and also urodynamic part. Yes, and yeah.
How big is the cohort? How big would the cohort be?
And if only from my hospital, it not more than 1,000 ค่ะอาจารย์ not more than.
And I asked Dan Apisara from our hospital. I think they have less than 100.
In
Very
Rama,
few in
really.
Rama because
Yeah.
it's quite rare here.
Yeah. So yeah ค่ะ so but the great thing is we have like for advantage of my hospital we have a data. I mean the majority. I mean if compared to other hospital, so it but it not greater than 1,000 ค่ะ
But are they are the data computerized in Sirinthorn Hospital?
During
Was
the
everything
during the time that we have the electronic medical record. I mean the electronic one half during the study period, only 5 to 6 years. Before that, we can extract the HM from ICD, but we need to manually.
So by electronic, do you mean every data points or text were typed in, or were they written on the paper and scanned like here? Scanned.
Again. Not computerized.
But the real computerized, they scanned, right? So that's in the format of image.
Yes.
And how's about the ICD-10? The ICD-10 for diagnosis that they coded ICD-10
by coder.
And how's about medications and urodynamic?
Urodynamic manually scan.
Scan in the image,
Yes.
as the image.
Yeah.
And how's about the finding of urodynamic?
Also the record in the scan. Like we have the form for record the parameter.
Typing
Now both typing and writing.
and writing.
Two sides.
Mix of.
Mix.
For the typing that may be able to convert image to text. And then text to exact information later. That should be able to do that.
Like X-ray report.
Yes,
That.
yes.
ค่ะ
I have a concern about the treatment. So first, for each form, you have the baseline form and follow-up forms. So what time period would one follow-up form apply to?
Time period.
Yes, would it be one admission, or would it be just one day, or one treatment course?
Okay.
You haven't explained that yet.
I plan to record every visit and admission, like OPD visit and admission period, and also the appointment for urodynamic investigation. These three parts will be used the follow-up form to record the data.
Yes. So how long typically would the treatment course be?
How long?
Yeah, typically how long would that be? A month or
Depends. I need to say it depends after we prescribe the treatment, whether we will have the appoint of the patient to do the other next evaluation, whether the patient can come to the appointment for months, for many months, or yeah.
What time is the most common after initially received treatment?
Most common
1 month? For
within 3
urodynamic,
months,
right? 3 months?
within 3 months.
Okay, within 3 months.
Within 3 months.
The patients might be performed with at 1 month or within 3 months, or even they lost follow up within 6 months or 4
Yes.
months later.
Yes.
Right.
Whether the longer waiting list of the test also has so many factors. Yeah, many factors have depend.
So that is the
This
actual practice. And what is the recommendation from the guideline after initially receiving treatment for this kind of patients?
No period that recommend.
Mm.
No period that can recommend, but the previous study like randomized control trial or the trial they within month.
Okay.
Within month.
Okay.
They test, but yes,
But actual data may be 3 months or even longer than that.
yes,
Like,
yes.
and the treatment will be continued afterward or stopping treatment if urodynamic show that is good result.
Continue the same dose.
Mm.
The
For
same
how long?
or
Forever?
for yes, and annually evaluate of the urodynamic will be done. Yes, yes.
So if the treatment is like this, I think you would face the same problem as Dr. Padwa, that the treatment can change over time. At first, they can have monotherapy.
Yes.
Later on, if the urodynamic measurements are not good, they can have combined treatment or switch to the other.
Yes.
Or sometimes they can switch back to monotherapy. I don't know. That could happen as well. So you have to think about this.
Yes.
How to cope with this situation. You would, because in your presentation, everything was clear cut like an RCT. You divide them into monotherapy, 1 or 2, first round or second round, then combine. So you have just 3 groups, but in real life, it's not like that.
So you may need to imagine the pattern of the treatments or possible patterns, and then think of how to deal with the treatments based on your data, okay, and how to emulate randomized control trial. For randomized control trial that they plan for whether monotherapy or combined therapy. And for the whole courses of the study, the patients would receive exactly the same as planned. But that is not happening or happen, but probably just half of all patients. The patients will switch treatment when urodynamic later show not good result, or they may add up the treatment on top of monotherapy. So you have to think of how to deal with the treatment regimens which vary over time. Now the way to emulate randomized control trial, both of you have to read the study that we work on T2D and we work on T2D mostly. That we have a few articles that we publish, and that may be good place and learn from that.
I wonder when was the combined therapy first used? When did it come in fashion? When did people start to use this combined therapy?
Oh, it is a state that for neurogenic. Actually, this treatment is basically from overactive bladder treatment in general population, and there is a standard dose for that population. But in neurogenic bladder, they recommend that will be higher dose or combined dose. The same dose as the general population may not respond. So in practice, we start the same dose as general, the dose as less that can control. And then we have whether we want to combine it, or whether we want to increase it. It can adjust in practice.
My concern is that if the physicians started using this in routine in just 5 years from now, in the last 5 years only, so retrieving the data back from 10 years wouldn't be of any benefit, because the first 5 years you would not have combined therapy, and the combined therapy is your intervention of interest. So you would start collecting the data when people started using this combined therapy. But if it's been used for 10 years already, so 10 years is fine.
But if monotherapy is one of your interests, that you can retrieve data before that, given the assumption or assume that the treatment regimens or other interventions during the 5-year period and the current after 5-year period are the same. Okay, you can assume that. You gain more number from monotherapy before period, yes. So whether the patients receive monotherapy or combined therapy, it depends on the baseline urodynamic, right?
Yes.
And you mentioned the selective antimuscarinics. So what are they?
During this time, the treatment of this therapy not only just scope in these 2 drugs. But it is limited in our practice setting and also in this group of patients due to the reimbursement. And these 2 drugs are the non-selective antimuscarinic type, which patient may affect more side effect than the selective one, which is the selective antimuscarinic, only few type of the drug, and beta-3 agonist that later used for control the bladder, but this not reimbursed in the universal coverage. But think of the 2 drugs that we use commonly in practice. We still lack of whether the combination or the increased dose whether we should adjust in which way. It depends on the factor, on many factors. So I think it may be the gap that we can study. So I select it as the commonly used in practice. Yes. And the reason I exclude these 2 drugs because interested intervention is this oxybutyrate and trospium. Yes.
But the patients who eventually received selective antimuscarinics or beta-3 agonists should have received oxybutyrate or trospium before.
Also depending if they can some patient will got this drug from other hospital for the first line.
So my suggestion is that So these two drugs may be used as a sensor factor, but the data points when they receive your oxybutynin and trospium before they receive these two drugs could still be used.
Oh,
Because you said you would exclude anybody who received these, but these can be considered second line, third line therapy, and some of them may have had received the first line, which are oxybutynin and trospium first. In those periods, the data can be used, I think.
so, oh, yeah, yeah. Thank you, Ajahn. May I ask, I will read more about the emulate randomized control trial, but is it limit with the sample size, Ajahn, to use this method? But I will go back to do homework more, Ajahn, but I'm not sure about this part.
So how will you know whether it's limited or not limited? So then you need to estimate sample size, right? Have you estimated sample size? And how many patients have you got in hands? Have you evaluated this? And that will be the answer. Okay.
Any comment or question ค่ะ Okay. So if no comment or question นัทพร
Thank you, Ajahn. Thank you.
Good morning, Ajahn and my classmate. My name is Nantapon Sitiko. My topic is association between Thai Healthy Eating Index and cardiovascular event and mortality in elective city generating authority of Thailand. My research question is Thai Healthy Eating Index associated with cardiovascular event, stroke and myocardial infarction and mortality? And primary objective is to assess the association between Thai Healthy Eating Index and cardiovascular stroke and myocardial infarction event and mortality in EGAT. And secondary objective is to assess the association between Thai Healthy Eating Index and all-cause mortality in EGAT study. For pickle framework population is EGAT employee will consist of EGAT 1/6, 2/5, and 3/3. Intervention is Healthy Eating Index score, and outcome is total mortality, stroke and myocardial infarction mortality, stroke and myocardial infarction event. Study design is retrospective cohort study. For the data collection and data record form, this slide show the timeline of EGAT that I will consider of this study. I will use the EGAT 1/6 EGAT 2/5 and EGAT 3/3 because 3 cohort have the Rama-Tibodi food frequency questionnaire in new version that can convert to the healthy eating index, and I will use the outcome of the total mortality and event that record until the December 2023. The conceptual framework that we use to data collection, I will consist of the unhealthy eating index that refer to the diabetes mellitus, hypertension, dyslipidemia, overweight, obesity, and refer to the metabolic syndrome. And the final outcome is ischemic stroke and myocardial infarction. For the for data collection will be conform the Rama-Tibodi food frequency questionnaire that will convert to the Thai Healthy Eating Index score. That is the total healthy eating index. The score range between 0 to 100 and consists of the 13 components. This slide shows how to calculate Rama food frequency questionnaire to the Thai Healthy Eating Index score. And for the data record form, will consist of the study variable that consist of the study subject. Demographic variable will consist of the date of birth, living place or site of EGAT study, education level, income, weight, height, body mass index, waist circumference, systematic blood pressure, diastolic blood pressure, and heart rate. For the family history of stroke and myocardial infarction, history of the stroke and myocardial infarction in the first degree and second degree relative, and number of the relative with the study participants of the first and second degree relative diagnosed with the stroke and myocardial infarction. History of the preeclampsia will consist of the number of the pregnancy, number of having preeclampsia, and date of having preeclampsia. And history of the autoimmune condition will record name of the autoimmune condition such as rheumatoid arthritis or lupus, and name of drug or dose of treatment, and history of illegal drug use that will collect of name of drug and dose of drug, and age of first use illegal drug, age of last use of illegal drug, and duration of use illegal drug. And underlying disease will consist of the diabetes mellitus that was defined according to the following standard criteria: fasting plasma glucose more than and equal 126 mg per deciliter at least 2 consecutive times, with the HbA1c more than and equal 6.5%, and taking oral diabetes drug or injection of insulin. Hypertension was defined as the systolic blood pressure higher than 140 mg per mercury or diastolic blood pressure higher than 90 mg mercury, and dyslipidemia was defined as the serum cholesterol higher than 200 mg per deciliter. Metabolic syndrome was defined when subject had 3 or more of these risk factors, including high blood glucose. That plasma,
Excuse me, Nanopon, can you summarize what factor that you will collect because this session we will discuss about the data record form.
For the case record form, we consist of the date of birth, age, gender, marital status, including married, single, or divorced, or separate. Education level will consist of the high school or less, technical, and some college, graduate, or postgrad, or unknown. And income, smoking status, alcohol drinking, and underlying disease. Will consist of the diabetes mellitus, hypertension, dyslipidemia, sleep, OSA, cardiovascular disease, chronic kidney disease, thyroid, chronic liver disease, fatty liver, and other underlying disease, and current medication and supplement, and body composition that will collect from the bioelectrical impedance analysis version 770 and hand grip machine, and laboratory record, and cause of death that will consist of the coronary heart disease, stroke, and myocardial infarction, respiratory disease, gastrointestinal, and malignancy, injury, and unknown. Thank you for your Thank you for your attention.
Okay, do you have any question from student? No question from student.
About for the data that you would like to collect, like illegal drug use or something like that, is it provide the case record form?
If they use illegal drug, they can define as the owner.
So this case record form, is it the one that used for recording in ECAN? It is already recorded, right?
I select some of the data that I will use to the study.
So this is yours. So this record form is yours. Is the one that you would like to use to extract from the ECAN.
I found that it's not correspond what the study factor or co-variable that you would like to collect. You present that you will collect preeclampsia, illicit drug use, but it's not, I cannot see in your data record form. And many of variable that you will collect in data record form is not mentioned in the study factor. For example, the body parameter, can you go to the slide that you will collect the such as FFM, what is FFM, ECW ratio, VFA, what is VFA, BMR, and what is your study factor, that is Thai healthy eating index that you not present in the data record form. In addition, your outcome such as cardiovascular event is not, you will not record this outcome. You present only the all-cause mortality. What is FFM, VFA?
VFA is the visual fat area, and FFM is the free fatty muscle mass, or all the data is export from the bioelectrical impedance analysis that I will use for the calculate the body mass index.
But body mass index just only use weight and height, right, to calculate and what this factor come from. It's not show in your study factor.
I record it because I think I plan for the secondary outcome. I think I will use like a muscle mass for the association with the total protein food or seafood and plant-based protein.
But it's not correspond with your study objective, right? It's not show in your study objective. The second objective is cardiovascular event or cause mortality is not in your objective. For the muscle mass or body mass, outcome, you not mention the outcome in your data report form. So the primary outcome of your study. To answer อาจารย์จริงๆค่ะ
I need to put the myocardial infarction and stroke event.
And how will you get the diagnosis of stroke and myocardial infarction in your outcome?
I review from the EGAT study is collect from the tool of more than two of cardiologists.
That is about history of disease, right? So you need to like clarify. I know that you get the data from EGAT, right? But the EGAT data has like many domain or many section. So you need to focus that which section that you will like related to your research objective. And then you need to understand how like how they collect the data in that part. Even though like another point that I'm not clear about your PICO, your study population is like patient, okay, from EGAT. For your research patient, what is the study design?
retrospective cohort study.
So for retrospective cohort study, we can change the intervention in these cases can be exposure, right? And comparator is non-exposure. Okay, what is your study factor? What is your objective? I saw that you like to determine or assess the association between
Healthy eating index.
and cardiovascular disease or cardiovascular event, right?
Yes.
So for PICO, you say like the intervention is high health eating index and comparison is no comparison. For your research question and your study design is retrospective cohort study, which is observational study, right? So you can intervention, you can change exposure and comparator is non-exposure. In this case, what is your exposure? High or low healthy eating index score is the risk of stroke.
Low healthy eating index.
No,
Low.
low is high risk. It means that low healthy eating index score is exposure and non-exposure is high healthy eating index score. And what is the cut off that you can say low or high?
The last time that we discussed, Ajahn said, for the healthy eating index score, we will use for the continuous data. So we didn't use the low healthy eating index score and high healthy eating index score. So I delete the low healthy index score.
But even so, you have to write it clearly that a healthy eating index score, different levels of this score are compared. So you can combine the INC domain, write them in exposure and comparator in the same item and healthy eating index. Not comparator, nothing like this. This doesn't make sense.
You can say study factor instead of intervention. Okay, if you don't want to subgroup or currently that you do not have the threshold. Okay, currently that you do not have idea about Thai healthy index score threshold, which is okay. So you consider it as continuous data, and then you can calibrate the threshold later. But to be safe, but because you're talking about a PICO framework, but it is now cohort study. It is cohort study. So you may slash intervention or study factor to be safe. And the EGAT study is not retrospective cohort at all. EGAT study is prospective cohort study, and they perform every 5 years. But the way you analyze data, that you analyze based on the data that had been collected already. But this EGATs now prospective cohort, not retrospective cohort.
Yeah, and I would like you to submit the assignment and the document before the meeting. You missing the assignment, right? And the document that you did not send to Mokida.
Can I have a look at your variables for data collection for this presentation? the data collection. I don't think you can get the date of birth. It is very confidential data for the date of date at the birth date. You can get the age, but you cannot get the birth date. And here that you retrieve the data from the EGAT databases. From EGAT databases. So here it is a part of demographic data. Can you go to the next slide? And the underlying diseases. Next. And the current medication. The current medication. So that you consider anti-hyperglycemic drug. You consider anti-hypertensive medication and lipid-lowering drugs. You may need to look at other few domains of medication for EGAT cohort as well. For example, the medications for heart failure, medication, the procedure for myocardial infarction, then they also retrieve the data and question the data when they interview the patients as well. Can you go to the next slide? And this is the body composition. This is the body composition. Next. And the laboratory. So the laboratory that you consider the fasting blood glucose, the glycemic level, and lipid profiles. And next you consider the liver function, the kidney function, and the thyroid function, and albumin level. Okay, next. And this is the part of the outcome. This is the part of the outcome. So actually that you have described for each domain that you're going to retrieve the data actually. But you may need to add more information how to verify the outcome. So here, this is the part of the cause of death. One primary outcome is cardiovascular death, right? Cardiovascular death, so that you have death from CAD, from stroke, for other vascular diseases, or for, and then that is the cause of death. And you may need to mention about how to verify this outcome, how to verify, and how to get those data to verify this outcome. Okay. Where is the part of the healthy index? Yeah, where is the part of that?
Healthy eating index. The record form will be like this table.
Only one form?
Yes.
Okay. Actually, you got our information for data collection, actually. But I need to mention more about or retrieve more about relevant variables that might associate with your outcome, and that should be covariates or confounding factor if you assess association between healthy index and the outcome. And how to get the data for verify the outcome.
Will you use will you verify this form by yourself or other nutritionists do it and then you get the final healthy eating index that you that they converted from the FFM. I don't remember the abbreviation, but you said it's converted from the form. Will you verify or validate it before you use it, or you just take it from the record?
The score has been verified by the three experts.
Don't need to worry about the verification of the score. You just get that number. So why you have to put all of that scoring? You want to they like you it's a paper, right? That everything is like written in the form, and then they finally get the healthy eating index as a single number.
Let me show you the.
Because if it is come as a single number finally, so what do you gonna use, like a very complicated form? I just think that you might want to validate it before you use it.
For the Ramatibadi FFQ will consist of the single food and portion of single food, and will use battery construction to convert to the score.
Finally, you do not validate the score by yourself. That they put everything, like they just ask the participant what did you eat, right? So finally, you have the score, the single score, right? So I don't understand why the record form is you have to put everything, like you try to validate by yourself before you use it, because the three experts that you said already convert the score for you. Is that right?
No. Three experts. Only the how to perform the Ramatibadi food quality questionnaire to summarize that we can cover the variety of the Thai food. I mean we put a lot of the single food item list to cover the more frequency of the food list that Thai people normally consume.
Understand that you have to expert to convert the FFM, the food questionnaire to food frequency questionnaire to the healthy index. So finally, you get the single number of that score, right? So I just wonder that your record form, you have like many items that you show. So look like you are going to validate not validate, to verify that the FFM that they corrected for you, and then converted to the high healthy eating index. So you want to check that, or just get the single number?
Yes, that is the part now for checking the data. It is different situation compared to other two presenters because now both of them working on secondary data based on routine clinical practices. But here is the planned prospective cohort study. It is a and prospective cohort study, and the data were planned now for collection. So you really need to explain about how to get the data, how to do data collection. How to do data collection, even though that already occurred, but you need to understand how to collect the data, particularly for the FFQ, the Fluency Food Questionnaire, and then convert to the healthy index. Okay, how to collect the data, whether it is interview, self-administered questionnaire, or it is interview. And how to check the data before you computerize the data, and how to provide the score, how to calculate the score. This is the part of data collection that you really need to provide when you present. And other laboratories as well, because they were blended data collection, not just retrieved from routine clinical practice, which is different. Okay, and that is the part of data collection that you have to show, you have to present.
For the FFQ, the registered dietitian, all of them have to train before interview at the data collection date, and for the EGAT cohort 1 and EGAT cohort 2, we interview by using the record form as the paper, and for the EGAT 3, about half of data using the paper record, and half of data using the red cap form, and of data collection, the dietitian asked for interview from the subject.
This is thing that you're talking should put in your proposal.
Thank you very much. Any comment or suggestion from student and อาจารย์นะคะ Okay.
Hello. Good morning, Jen and my colleague online on site. So today I would like to present my data collection process and data collection form for my research work. It is to compare the effectiveness and safety outcomes of moderate intensity versus high intensity for patient with coronary artery disease. And my goal in general is that population is patient with coronary artery disease. It might be any kind. The intervention is moderate intensity setting. The coronary rate is high intensity, and the outcome is primary, secondary, and safety outcomes. So I will explain very detailedly in data collection about the outcomes. So generally, I'm thinking to collect the data from who's my cohort from the very but I need to create this cohort, and I'm the main responsible person to collect the data, but it is with the help of data scientists and other team members. So there may be two main forms. One is enrollment form, and another one is follow-up form. And I will use these forms in Epidata software. Then enrollment period is from 1st January 2008 to 31st December 2009. So it means a 2-year period. During this period, I will identify my participants. The follow-up period will be from 1st January 2010 to 31st December 2020. It means it has 10 years follow-up. And after data collection, I will mark the form with the ID, hospital number, and then export as a stated file after checking double entry, cleaning, or some usual procedure. So the detail will be in the Excel file, like this. So in enrollment form, so I mentioned the enrollment periods. So I will collect the records during these electronic medical record during these periods, and check for inclusion criteria like age, diagnosis. So, and the date of diagnosis, taking statin or not, and the exclusion criteria as well. But this is for, I suppose there may be very large volume of cases there. If I can identify, for example, like chronic liver disease, and the definition of chronic liver disease will be here, like alcoholic cirrhosis or liver due to alcoholic hepatic failure or something like this. So if I take here, then it means I will not collect the remaining data like this. If not, then I will collect the exposure status like name of study, but it must be the generic name, not the trick name. The dose is milligram per day, and the maximum dose is 80, so only 2 digits. The start date, if they change the dosage, then change to which dose and the date of change of the dosage. And the usual social demographic factor like gender, date of birth, the residence, it means the name of the town, the education level, like an educated high school graduates, income, birth per month, so it has 6 digits. And the occupation, risk behavior like this, it's a past history of MRI, heart failure, atrial fibrillation, and family history. It means first degree relative parent, sibling, and children. Family history of cardiovascular disease. And the physical examination, systolic blood pressure, EBP, height, weight, it's for to calculate BMI. And the comorbidities, diabetes, renal disease, peripheral arterial disease, dementia, previous stroke, and the definition will be here like this. And laboratory finding, the most important LDL-C level, to the cholesterol and CKMB troponin for to confirm myocardial infarction. This is for renal, estimated GFR, serocreatinine, blood urine nitrogen, for liver, EST-ELD, for DM, fasting glucose, HbA1c, and the date of the laboratory test. So for severity assessments, so it will be 3 vessel disease, 2 vessel left main artery, and time ASCVD score. And for intervention, so I will collect, is it medical treatment only or any surgical intervention like PCI? So PCI may involve any forms of angioplasty, any forms of stent replacement, maybe drug eluting, or it may be very metal or any other damage procedure. So if it is just then, I need to specify the date. Or maybe coronary artery bypass surgery, it can be of any type. And if it's just then, I need to specify the date. And finally, I will collect information about co-medication, like antiplatelets, any kind, aspirin, clopidogrel, ACI, ARB, beta blocker, nitrate, and the details of drugs will be here. So this is the baseline form. So after identification of the patient and collection of the baseline form, so I will make another follow-up. I will use follow-up form using the same subject ID number, maybe hospital number, and then I will check for follow-up. So it may include date of follow-up, number of follow-up, and the depth. So firstly, I will collect in the follow-up form. So I will collect the exposure. Firstly, the exposure status, the name of study, dosage. If they change to which dose, and the date of change, and the laboratory finding for follow-up as well, like this. And if they have here non-fragile amine, then I need to specify the section 3. So for LDL level to the cholesterol, especially for confirmation of the diagnosis, CKMB, troponin, or something like this. and then intervention type as well. So this is, and for safety outcomes, so I will collect the statin related adverse event. So I will collect only statin related adverse event, not other adverse event. So like this, the date of the adverse are muscle pain or weakness, rhabdomyolysis, newly onset DM, and if there's any hospitalization due to statin-induced adverse event, then it's date of hospitalization. And other adverse event, this is just to know what are other adverse event here, but it's not for analysis. I just want to know here. And the study discontinuation due to adverse event, if yes, so what's the date of discontinuation? And if they reinitiate, sometimes it is possible that they discontinue their statin for a week or maybe 2 weeks, and they will reinitiate. In this case, I will take into account the use these cases as exposure according to some previous literature. So after that, there might be some missing records. For example, if I can identify 10,000 records in baseline and in follow-up, so I can identify 8,000 records, then 2,000 records missing. It means that it might be due to that. So I have to check another data, that registry or that database of the Rama using these ID number. And then if I can identify these ID number in that register, then I will collect the date of death, the cause of death as usual. And if all others are the same as the way that I collect in their baseline data collection. Okay, yes, that's the end of my presentation.
You, any question from student? Question from student? Enough, can you ask some question? Compare with my study, Mr. Tun, you have a large number of population, right? So, is maybe the same as Ajahn comment in my project. So it will be need to be report in flow chart, right, Mr. Tun?
Yeah.
And extract the ICD, right? The mainly one, like inclusion criteria and exclusion criteria will mainly extract from ICD, right? I remember last time, Mr. Tun.
Yes, both ICD here, because of change in layout, so it is like this. So in here, I present both the name and the ICD code. In this case, it is ICD code I-20, it means angina pectoris. So if they use ICD I-20, then it's okay. Or if they didn't use, then I have to check the physician diagnosis, physician notes on electronic medical record. If I saw angina pectoris or something like this, then so I will take there.
And all of exclusion criteria can use ICD.
No.
No. Right?
No. So here, yes, you have good questions. So I put exclusion criteria very detailed here just to visualize myself and to make the data record, data collection speedy. For example, if I can find someone like this, chronic liver disease, and tick, then I can safely remove that record, which means I don't need to spend time on these data to collect these data. And for some cases, for example, like number 4, stop statin therapy within 6 months after initiation, it is just visualized, it is available in the baseline form. So because I can use these information only after data cleaning. So I have to extract the date of initiation and the date of discontinuation. For number 6, like cytochrome P54, I think it might be a little bit difficult, but it is possible. For example, if I see these prescription by the doctor erythromycin for 2 weeks, then I can safely discard that EMR.
Cytochrome P450 inhibitor, that you have the list of this drug or not?
Yes, it's very large amount of drug.
More than 2 weeks from what is the date that you count the duration of cytochrome P450 inhibitor?
Yes, if they prescribe, for example, erythromycin 14 days, like this, or in some condition, for example, HIV. So if I can identify patient with HIV, then I have to check the treatment. And if it is under cytochrome P40, then I can remove. But it is quite cumbersome. It's quite difficult, but I think it is quite possible. That's why I can include.
for the name of the statin, I suggest that maybe you list the possible name that, for example,
yeah.
Simvad,
Yes, atorvastatin, atorvastatin. Yeah.
something like that, it will be easier.
Can I add some comment? Because you are using the electronic medical record, no? and and there will be like a lot of visits that probably not related to this kind of disease. For example, they come for other treatment in the hospital. I'm not sure whether if you would like make a form like this, it will be useful. Because you are actually identifying from the ICD-10, ICD-9, and medication and probably laboratory. If you design a form like this, it's not useful for your implementation of all the data collection. I think probably you might need to design based on the data, or you get where the data is. For example, you get the data of the medication that they use from the medication database. You get the diagnosis from the diagnosis database, and you get the outcome data from elsewhere or in Rama Hospital as well. Designing from the data would be better in this case, unless you will extract the data by yourself, but that would be not useful anyway, because as I said, that if you consider every visit to the hospital, that will be like a lot of work for the data that is probably not worth the time. For example, they come for the wound treatment or the other things that are not related at all to this problem. Secondly, you are trying to identify from the outcome from the ICD. You should probably add the verification to ascertain the outcome as well. For example, your outcome was like the recurrence, right? Or the stroke or something like that. Maybe it would be better if you add in, for example, if they were recurrent, they should have repeated procedure performed on them, or some medication that we use for on them, or some laboratory value that support the diagnosis of your outcome. Probably you need to list the outcome and how will you ascertain that the outcome actually happen, whether it's through ICD or other thing as well. And I'm not sure about what another point, why you consider only 2008 and 2009.
Yeah.
Why only those 2 years?
Because I'm supposed there are very large number of cases. It is the incidence rate of C80 coronary disease in Thailand is a little more than 2,100 per 100,000 population. And in Bangkok, so I think it's mega city, and at least 1 million people, according to that regulation. It might be at least 20,000 cases in 1 year.
My point is that if you only consider that 2 years, then I'm not sure about the completeness of the follow-up period, because it was quite.
It is from enrollment period. So I can identify my participant only for 2 years.
Yeah, I understand. But
I have a follow-up for 10
do you
years.
think about the follow-up, loss to follow-up in those kind of problems?
Yeah.
Because it was post MI for 10 years, probably the patient go elsewhere or did not come to follow up. If you pick the year to be very far away, so there will be a lot of chance that they did not come during 10 year or the 10 year. Think about that as well. ครับ that's my
Any comment ค่ะ from other students ธันวานันทพรคอมเมนต์ทุกคุณสสทุน I think it's very good that you prepare a lot of the risk of the variable that you need. But my question is, how will you plan to collect the data? By data retrieve, like a data retrieval from database, or extract the data from medical record.
Yes, in here, so it is to extract the data from electronic medical record. Because in my knowledge, there is no cohort, no CD cohort.
I think in case that you would like to retrieve the data, you need to create the flow chart as Dr. Thanwa, to get the idea what database that you will retrieve for disease or for the treatment, and determine like the duration. And another point that I think you need to specify the detail of the outcome. For example, your event of interest is cardiovascular event, right? And what is your P population?
Population with
coronary artery disease. And in case that you get the data from the database and you have date of diagnosis, right? And how do you define the outcome? The outcome should be like occur after receive the treatment, right?
Yes.
Yes, you need to like specify clearly about like you get the data from first diagnosis, about diagnosis cardiovascular disease during 2009, and then for the outcome, and after that you exclude some exclusion criteria that you explain. But I think this is very short. Just say that you exclude this disease, list of the disease that you exclude. But I think you need to specify clearly that this disease occur before receive treatment. Yeah, so you need to, yes, it means that you think about when you retrieve the data, how many conditions that you specify that, okay, this record is the outcome, or this record equally. So I think that the date of all event is very important. If you just read like this, you will not not get the idea on cannot imagine how you get the data.
Yes, and during these videos, any condition actual this is
I think this is good for the risk of the variable that you will focus on, but you need to create the flow chart for data retrieval that we get the idea like how the database that you can get the information from hospital database or from for example that you would like to diagnose the cardiovascular disease, but I'm not sure that it is necessary to use the laboratory result or imaging to confirm the patient. Yes, I think you will get the idea how to identify the population. The same meaning as how to retrieve the data. That is the information that you show is just only the part of data collection. But to make it completely, you need to prepare the flow chart for data retrieval.
Thank you, Jen.
I understood that you are not going to review medical records at all. You're going to keep and identify the data from hospital databases. You may review the medical record just in case that there is no information to let you ascertain they are coronary artery diseases, or you may need to confirm the outcome in case that the data that you would like to retrieve in order to verify the outcome that is lacking for some cases, but not as of impossible. Okay, that is one point that you may need to think of. And when you include the patient's coronary artery diseases that indexed by ICD-10 or indexed by the procedure, relevant procedure that they were diagnosed as coronary artery diseases, and that case identification. And when you work on that you really need to think of how to manage the data, how to read it. Okay. And you may need to think of not just the 2008 and 2009, because the bigger is better. Okay, the number of cases, larger sample size, and is better. It depends on how you will be able to handle the data. That's all. But you should not limit yourself within only 2 years. But how long that you will take that include the patients? It depends on the onset of the disease. The onset of the disease or event of interest, that is pre-operative infarction, re-stroke, that are events of interest that after the receiving hydrocephalus. So you have to think of it. That will let you plan properly how long you will include the cases. Since 2008 to 2000, for example, 2022, if you're going to retrieve until 2022, if the onset is at least 1 year, for example. Okay. But not limit yourself not only 2008 and 2000. That's not useful yet, because larger sample size is better. Okay, and also there may be some of them lost to come up as a gentleman just mentioned. So why not? They include as many as possible, but given the index of the onset of the disease, the reoccurrences of cardiovascular event of interest that you have to think of. Can you move down? Can you move down? So you really need to think of comorbidity of the patient. Most patients who have coronary artery disease, other comorbidities in terms of non-complicated diseases that also induce or reduce occurrence of and the specific treatments for CAD, and for other comorbidity So we really need to think of that and try to understand and target and other procedure of simply that we need to think of and include here.
Yes, and include in baseline, but compared to include in follow-up.
They are not, they are not, they are not. And you need to work on longitudinal data, not just the baseline data. Okay. Not too simple now for PhD student. That's very easy to work for baseline data only, but not for PhD student. Okay. It must be targeting covariates, must be targeting treatments. The treatment of CAD should be vary over time. Relevant treatment for CAD, not specific for CAD, but relevant for CAD in order to lowering or prophylaxis of stroke, prophylaxis of re-event of myocardial infarction that you should consider. And they are vary over time, they are not fixed over time. Okay. Don't be afraid to work on big data and time-varying covariates. That is for PhD.
Don't forget to include other anti-lipid medication such as the gemfibrozil, phenobarbital.
I'm thinking to exclude these other anti-lipid drugs because I want to isolate the effect of statin role.
But some patients have mixed dyslipidemia, right? They also have high level of LDL and high level of triglycerides.
Yes, that's happening. That's happening. Don't think of beautiful world for working on level data. Okay, otherwise you have to exclude 50% of the patient, and that's not good representative of the whole patient's either. Okay, so why not? There is a way. There is a way how to adjust for those effects. There is a way how to work on causality effect. Okay, there is a way. So why not? Don't think of just beautiful world.
Other drugs other than statins, such as the PPSQ 49. I cannot remember the exact name, but the other medication other than statin that used to lower LDL level in very high LDL level. Any comment or suggestion? Okay, thank you very much.
Sorry, I forgot to mention about how to verify the outcome. So they really need to think of other databases, a few databases that to verify the outcome, including the procedure ICD-9 for re-myocardial infarction, like CABG or PCI, or other CAG means coronary artery and coronary angiogram. So that now if you think of this data in order to verify the outcome from ICD-10 and ICD-9, that will be very useful, and that will strengthen your study. Okay.
Thank you very much ค่ะ Any comment ค่ะ No for the last presenter ชอต่อทน
Good morning, Ajahn. Today I'm going to discuss about the data collection and data record file. So here's my title, protocol title. So firstly, let me start with the research question and objective. The amend patient with pulmonary arterial hypertension. What is the comparative effectiveness and safety of combination therapy versus monotherapy based on the real world data? So there will be three objectives to assess the effectiveness and safety of the combination therapy compared with the monotherapy in terms of primary and secondary outcomes and the adverse events. And the third objective is to control the effectiveness and safety of different combination therapies. So here is the framework. The population will be patient with pulmonary arterial hypertension. The intervention will be combination therapy, whether it is dual or triple therapy, and they will be compared with the monotherapy. The outcomes will be primary, secondary, and the safety outcomes. So the participant, as I mentioned before, participant will be the patient with BH, and I will select the participant according to the inclusion criteria and exclusion criteria. In the study filters, I'm categorized into 4 domains. First one is the demographic and baseline characteristic, and the second one is the clinical characteristics, investigation, and the medication. The primary outcome will be the clinical worsening, which is the composite outcomes. And the secondary outcome will include the 5 different variables, such as the 6-minute walk distance, WHO functional class, BMP, right heart catheterization, and the echocardiographic parameters. And the safety outcomes will be the adverse events. So in the data collection, I will extract the data from the electronic medical record of the Ramat Hospital from the 2010 to 2023. So the information will include the demographic, clinical characteristic, medication laboratory result, as I mentioned before. And the data collection and retrieval will be done by me and the data scientist. So here is the data record form. So I will use the 2 forms. First one is for a baseline data. So it will include the 4 domains, and the first one is the demographic and baseline characteristic, including the gender and social factors like smoking, alcohol drinking, education, employment status, and also BMI, will be calculated from the body weight and height. And then another one is the clinical characteristics, which will include the blood pressure and some signs and symptoms of heart failure, reassessment, WHO functional class, and 6-minute walk distance. And I will also collect the underlying causes of pulmonary arterial hypertension and comorbidities. So investigation will include the echocardiographic finding, right heart catheterization finding, and the other laboratory results, such as the BNP, liver function test, and hemoglobin level. So here's the medication. In the baseline, I will collect this information. For the pulmonary arterial hypertension targeted drugs, I will collect the class and the specific drugs, their dose, milligram per day, dose in milligram per day, and the start date and end date. And I will collect the other medication as the covariate, which will include the diuretics, anticoagulant, and oxygen therapy. So this is the form for the follow-up visit. So it will include the clinical characteristics, investigation, the same as the previous form, and medication. And I will also collect these 3 variable for calculating the primary outcome, which is the clinical worsening. So which will include the death, lung transplantation, and hospitalization. I will also collect the adverse events. For this one, adverse events, for example, hypotension and anemia will be collected according to the investigation result. And for other adverse events, I will retrieve from the electronic medical record. So after listening to the previous speaker, I realized that I failed to construct the another form, which is the eligibility form. So for this eligibility form, I will construct according to the by looking at the participants inclusion and exclusion criteria. So I will find the different disease that includes in the inclusion and exclusion criteria by using the ICD-10 or ICD-9. So this is my end of presentation. Thank you.
Thank you. There is any question, comment from student? Can you ask some question?
Yes, please go to the follow-up one. So the first one is the number of visits. So you think the number of visits should be less than 9, right? There's only one spouse there.
Yes, because my follow-up duration will be mostly 12 weeks or 3 months. So only for the outcomes, which is the echocardiographic finding, I will collect for up to 1 year. And also and one thing is we really see the patient every 3 to 6 months. So I think that's the reason why I use the only one blank in the number of visits.
Yes, on next slides, so echocardiogram finding. So yes, in the title, echocardiographic findings. So how do you verify or how do you know just reading their cardiologist record, or I'm not sure how you verify these findings.
So I believe that I can get these echocardiographic findings from the electronic medical record. Yes.
Okay.
And what do you have question?
Yes, some small question that for the follow-up form that you would like to collect the data for physical examination for like, can you go to the previous slide, please? Like for the sign of heart failure, like hepatomegaly or engorged neck vein, how can you verify this finding in the electronic medical record? Not sure whether we can.
Yes, firstly, I thought that so I can collect this information from the medical record because these symptoms and signs are very important point for the patient with pulmonary arterial hypertension. That's the reason why I believe that I can get these parameters from the electronic medical record.
The main point is that you would like to collect something that like to identify the heart failure, right?
Yes.
Only the physical examination.
Yes.
Other questions? I have one question about the SIN code that you will record, right? So
Yes.
you will record the date of SIN code or not? Or just only present or absent during the follow-up or at the baseline?
I will collect this information both in the baseline and follow-up because this is the important things, and it's also we also need to get the information to assess the to make the risk assessment as well. So I will collect it both in the baseline and follow-up visit.
But you have to record the date of syncope or not. Yes, and the syncope, that's it. You have to verify that this is syncope or just only dizziness or something like that. Or the syncope make the patient come to ER or not, something like that. You will record or collect or not. Or the type of syncope. If this is not the cardiogenic syncope or it's vasovagal syncope, you will include, or you have to specify the type of syncope. And for the baseline data record form that you collect the syncope, you will trace back how long that you will trace back 6 months or 3 months before the date of enrollment.
Yes, and I think I will collect within one month.
1 month, okay. And how many syncope you would like to collect the number of syncope or not?
And I don't specify the numbers of syncopes within 1 month. Yes.
But maybe some patient may have more than 1 time, right? Some it can happen or not? That they have more than 1 time of syncope.
Yes, Ajay. Yes, they can be, but I will only collect whether there is the occurrence of syncope within 1 month.
And for the vital sign, you will record only systolic and diastolic blood pressure, but about the heart rate, or pulse rate, you will record or not?
And I put this variables because I want to I want to define the hypotension as an advanced events. Yes. So if the patient have the hypotension, I will collect the advanced event as the hypotension. Yes.
But for the pulse rate or heart rate, you will record or not? You will collect, not collect?
No,
Heart
I yes.
And for heart failure, you will collect sign of heart failure, but the result from the for other signs such as the pulmonary edema, you will collect or not? Pulmonary edema.
Yes, I'm sorry. I'm failed to mention about the heart failure, because this is only for the right heart failure. So we cannot collect the pulmonary edema. Yes, this is for the right heart failure. I'm sorry.
And for the edema, it's the one side of right heart failure or not? For the edema of both legs or?
Yes. Edema is the right heart failure side. Yes, very edema. Yes, I will add this information.
May I have some question? May I know about the type of the disease that you're looking? You are collecting the data of the type of the
Yes,
as well, right?
yes.
Yeah. For this one, how will you get or who will define this? And is it can be like unknown or undetermined, or how will you how will you like get this data?
Yes. I will use the ICD 9 or 10 again. So for the idiopathic pulmonary hypertension, here, for the idiopathic, the ICD code is 416 or for the ICD-10 is IN27. For the other pulmonary hypertension associated with maybe HIV or chronic tissue, so I will use the ICD-9 and 10 like that.
So only from the coding of the original ICD, right?
Yes.
Okay.
Can you please?
Thank you for your presentation. I will start from the form, record form. First of all, data collection that you mentioned that you will use the just only the group 1 PAH that you might have to put it in your type of for the form A at baseline. You have to put like the type of the diagnosis, like let's say connective tissue disease or list of the type of diagnosis of PAH. And also from the date of enrollment, what do you put on the date, like date of diagnosis or date of initiation of therapy? So you have to specify, like I recommend to put this on the date of diagnosis because some patient might have been referred to our hospital with the before with the diagnosis before. If you know the date of diagnosis, then you might know how long that they get the will the medication start after diagnosis, and that might affect the outcome that you will see. The longer the delay, the poorer the prognosis. And the risk assessment that you put low, intermediate, high, I don't think that you can find it in the medical record because this thing has been calculated for many factors like 6-minute walk test or syncope history, that you have to record all of these parameters and then you use the calculator score or calculate table to put it in your risk by yourself. And for this investigation, you might have to tell that you record from the EMR, what part of EMR, because these things are not recorded in EMR. It might be in the database of the cardiology department or what else? You have to clarify more what where you get it and at what visit that you will get this. And for the medication that you use these 3 groups, like I think you might miss one for the PGI2, that Belacross, that another one that use it in the early or early period of the PAH treatment in the hospital because it's cheaper and even though it's in the 3rd class and the 3rd line vasodilator, but it's cheaper. It might be you have to put it in there as well. And you have to know that the medication for PAH, we never stop the first line and then at the second line, we never do that. We just add on. So the end date of the
PDE5 inhibitor might not be found. Okay.
Yes, Sajid.
And what else? I think you might have to list for this medication, if you might have to list which one, for the dual treatment, which one is combined. Possible for the possible dual combination or the triple combination, which one that can be used. Okay, not like pick one box and then maybe you will miss something. And for the other medication, I recommend to put the name of the medication, the dose, and the date of medication that the patient received. But first of all, I want to ask you that I'm going to review the EMR because I know that you will not come here. How come that you will you get the EMR from the hospital because you are not here, right? You will not be here on the course. You might use the database instead. And again, if you use database, you have to write the flow chart that how you get these database from what database, like echocardiogram database or ICD-10 or right heart cath database, something like that. Can you?
Yes, Sajid.
I think that you should mainly work on secondary data based on the hospital system. And you may need to review the medical record for some medical record, not as a whole. Not as a whole, either for identify the cases. The case here is pulmonary hypertension. Now after you revise the flow, how to identify the cases from ICD-10 and ICD-9, and that is not enough at all. You may need to think of, now if you look at our website, and you can see the flow, identify the flow for heart failure, for example. Now look at heart failure identification, and that you will get the idea how to link ICD-10 or ICD-9 or ICD-10 with medications and with right heart catheterization and echocardiography. Okay, and that identify the cohort. And after you identify the cohort, you have to form the cohort in terms of the treatment of interest and carry now with the covariates now for each visit. Then the treatments now also vary over time and the outcome of interest. Okay, and how to verify the outcome. Luckily that your outcomes are hard outcomes. And that should be able to verify now based on the data straight away. Okay, or a few now of them may need to link with the echocardiogram again. But mortality is mortality. Do not need to link with other at all. Okay, and hospitalization, that's quite straightforward for hospitalization. So I think that now the way to work on your data now should be similar to the way that we are working on heart failure. Okay, and then you can look at that as the example, how to identify the cases, now how to ascertain the cases to lowering misclassification of the cohort. That is the start point. Okay, that is the start point. And I rather avoid to mention about the date enrollment for all projects that you guys mentioned about the date enrollment. But instead of the date enrollment, now the date diagnosis of that diseases, the date now receiving the treatment, And which one or another later on that there should be the index date later that you can define. But here that you collect the date, now that we went to that event, the diagnosis or the receiving the treatment. Will you be able to come to Thailand? So to
I'm not sure, Ajay.
have you thought of this to come to Thailand?
To be honest with you, I desperately want to come to Thailand, but because of the situation, so it's not
Yes.
possible.
Yeah, let's find out. Let's find out if it is possible. Okay.
Yes, Ajay.
Otherwise, that you have to work from there and work based on data from our system. But if you can come, that is better. Alright?
Yes, Ajay.
Any comment and question? If no comment and question, thank you very much for your participation. And please submit your assignment before the due date. And so I have enough time to comment and send back to you before the presentation. Okay.
So students, tomorrow is the first time for systemic review and meta-analysis courses. And that will be started at 9 o'clock. Okay, please be on time. And I will demonstrate about the courses, for the whole courses, RACE618, and the detail of the course and the requirement now for the whole courses. Okay, please be on time.